Dear colleague Benabba, today we present a case of pulmonary lymphangioma that arose at the 25th week of gestation in one of the two fetuses of a dichorionic diamniotic twin pregnancy. Lymphangiomas are infovascular malformations caused by a defect in the connection between the lymphatic channels and the venous system. On ultrasound examination, these appear as cystic, multiloculated, and septated masses described with a honeycomb appearance. They are indeed referred to as cystic lymphangiomas. As we can see from the images being shown, these appear as septated cysts with an anechoic content and no solid tissue inside. The septa have variable thickness and can be more or less vascularized, such as lymphangiomas are located in 70% of cases in the axillary region, while in 30% of cases they involve other areas, such as the trunk and limbs, the mesentery, and the anterior portion of the neck. We now show you some frames from the second trimester screening ultrasound performed at 20 weeks. As can be seen from the following images, the lesion was not visible on the screening ultrasound. The patient returned to us at the 25th week of gestation due to the appearance of this septated cystic formation, affecting the left thoracic limit of the male fetus. Some important characteristics of these lesions are their propensity for growth and local invasion, potential infiltrative nature, and mass effect on adjacent structures. Obviously, depending on the anatomical site where they develop, we will encounter different types of issues. Axillary lymphangiomas can limit arm movements, cause rib deformities, and lead to pleural effusion. Lymphangiomas of the trunk and extremities can cause lymphedema and limbs with abnormal posture. Mesenteric lymphangiomas can cause compression of abdominal organs and ascites. Cystic lymphangiomas should be differentiated from cystic hygroma, which accounts for 80% of all lymphangiomas. It is important to remember that it is located at the posterolateral neck, is associated with chromosomal abnormalities in 2/3 of cases, and fetal hydrops is common. Another condition to consider in the differential diagnosis is Klippel-Trenaunay-Weber syndrome, which, however, is characterized by a large cutaneous hemangioma with a solid component and blood flow within it. Additionally, there is often associated hypertrophy of a limb with asymmetry of the long bones. As specified, these masses have the main characteristic of tending to grow during pregnancy. However, in our specific case, as seen from the images shown from the examination conducted at the 30th week of gestation, the mass had dimensions that were almost unchanged compared to the examination at the 25th week, with no evidence of thoracic effusion, pericardial effusion, or fetal hydrops. Even though rare, especially in cases of non-vascularized cystic lymphangiomas like ours, potential complications that may arise include fetal growth restrictions, fetal hydrops and anemia, neonatal respiratory compromise, if the mass involves the airways, and possible obstructed labor, particularly in cases of axillary formations. The prognosis in these cases is good with 29%, showing partial involution, and the smaller non-septated forms have a higher likelihood of resolving it spontaneously. The risk Beaulieu score of aneuploidies in cases of isolated lymphangiomas is very low. Therefore, the course of action will be an MRI for better characterization of the lesion itself. and pediatric surgical consultation.